Dear colleagues, welcome to our monthly dialogue. You know by now very well that our dialogues are live streamed in YouTube and recently also in our Twitter accounts. And this initiative, this monthly webinar, this initiative has been remarkably successful for two reasons. First, for our guests who are top cardiologists in the world. And second, for thanks to all of you, because our dialogues are always very interactive. The dialogues are not between editors and guests, but our dialogues are always very lively and very interactive. So I start by asking you if you have questions. Please ask your questions. You can write them in our chat, or you can raise your physical hand or your virtual hand, and we will unmute you and you can ask your questions directly. And it's now a great pleasure to announce our guest for today. She's a very important woman. Among the other things, she is the chairperson, the chairwoman of the Guidelines Committee of the European Society of Cardiology. Our daily life is definitely influenced by guidelines. Guidelines are inspiration for all of us, and Eva is the chairman of the Guideline Committee. And it is also a great pleasure to introduce Rasha Al-Lamee. She's Associate Editor of the European Journal. So we are both the host and Eva is the guest today. And the title of this interesting dialogue is Prevention, Women in Cardiology and Guidelines, a dialogue with Professor Eva Prescott. Now, Rasha, we are ready for you for your formal introduction of our guest, please.
Thank you so much, Filippo. Thank you so much, Eva, for joining us today and for all the audience at home. So it's a real pleasure to host Eva Prescott with us today. She's a clinical professor of cardiology at the University of Copenhagen, and she's also head of the Center of Cardiovascular Research. She's participated, as you've heard, in writing many guidelines that have really influenced our practice, and she's the current chair of the Clinical Practice Guidelines for the European Society of Cardiology. Eva is also a member of the Danish Council for Independent Research, and she received the prestigious Danish Society of Cardiology Scientific Research Award in 2011 for her appreciation of research. Importantly, in terms of her research interests, Eva has main research interests really in coronary artery disease, in risk prevention and in diagnostic strategies, and in particular in treatment and prevention. And she's really recognized for many of us as an international expert in coronary microvascular dysfunction, but also importantly in risk prevention and in guiding what we do every day in our cardiology practice. She has lots of interests beyond that, and I think we'll cover some of this today in terms of gender differences and psychosocial factors and how they influence disease patterns. And of course, she has been the PI of many influential trials and has published more than 350 papers. So that is really a very impressive biography, Eva. It's a pleasure to have us with you today. And thank you very much for giving us the time to join us.
Thank you. I'm really looking forward to it. It will be fun.
Thank you. So maybe we kick off the questions today. And Eva, I'd like to, for many of us who kind of are in your shadows and have watched you over the years, and you've really pioneered much of our cardiovascular research, can you tell us what stimulated your interest in cardiology and why you wanted to choose this career?
Yeah, you're using very big words. Maybe we should. Makes me feel a little bit uncomfortable with those very big words. But I will tell you about how I started on this. And this was I became an MD in the early 90s, and at that time the women in Denmark had a very unfortunate world record, I think, in lung cancer, and we had the lowest life expectancy, one of the lowest life expectancies in Europe, and this is Denmark. You know, we're not supposed to be there. So there was a lot of focus on that, and I started research and PhD in epidemiology, trying to look at why is this that women have such poor life expectancy. Of course, a lot of it was smoking. Women had, you know, we had these northern ways of life, a lot of equality, and the backside of that was that we also started smoking just like the men. So when you live like men, you die like men. So we had, you know, these poor life expectancies, and we wanted to look into what is there more to it. You know, how much is the lifestyle? Is there more to it? Is there also a difference in susceptibility? Now, this is a long answer to your question, but we wanted to look at, is there more a difference in susceptibility to, and I looked particularly at smoking, and we found that there wasn't a problem with lung cancer, and there wasn't a problem with lung disease, chronic obstructive disease, but there was a problem with myocardial infarction, in fact, that women seem to be more susceptible to the effects of smoking for myocardial infarction. Others have shown that also later on. And that was part of what drove me into cardiology. And then also at that time, that was when we were really also in the Western countries really dying from cardiovascular disease. Since then, it's declined very much. Of course, it's still very important, but at that time it was really number one killer. But there was so much you could do in opposition to pulmonary disease and oncology. At that time, we were really rapidly progressing with all of the treatment options that were being developed, and all these large trials over there in the 1990s. So that was really what drew me into cardiology. If you wanted to be somewhere where you could really, you know, had treatment options, a lot of trials going on, and it was really that's what brought me there. And then the beginning was that I looked at these women in Denmark who had a lot of heart disease and other things driven by smoking and lifestyle.
So presumably in those early years, and you're kind of thinking about a career in cardiology, were people putting you off? Did you have people say there's very few women in this career? Did you listen to those voices, or was there supporters out there to help you?
Well, I unfortunately never had a mentor, because my mentors were in pulmonary medicine, and I moved on to cardiology. So I never really had a mentor to sort of, and it was a bit difficult sometimes. You know, a lot of men who didn't want to hear about prevention. So, but I'm not going to complain. You know, also things have also been easier. Sometimes things are also easier when you're a woman. So I think.
It goes both ways. Yeah.
It goes both ways. But,
yeah.
you know, still, you know, we used to say then it's a question of time. Things are changing, you know. But then when I look at it now, I was the first female professor in cardiology in Denmark. And that was back in 2009. And now we have 2023, we have 2 female cardiologists. Okay. So it's not really changing very rapidly.
No.
And I think we have a problem still with models, role models. So I hope that's going to change, but I don't think it's going to change without doing something actively. And you know, I know it says it's a dialogue. I could ask you the same question.
You're in the camera today. Yeah.
Okay. Well, it works both ways. I can't say that you know I've been held back, and also I have a husband who's also a physician, and so we very much share the work with the children. So I had 3 children, and we've been able to share things.
And can you tell us, Eva, to come back to sort of your choice of career, why prevention? Did you ever think about doing something else, or what was it about prevention that really triggered your interest?
Well, I don't know, if you always want to do things that have an impact. You know, everything you do can sort of, of course, as a physician, you can always have an impact on the individual patient. But if you want to do something in research where you think it's going to have big impact, there's no question that prevention is better than cure and so on. And there was a lot to be done at the time. I mean, you can't look at cardiovascular disease without getting prevention. It's such a big thing. So it seems like a little bit, you feel that you're sort of missing the point if you're only treating, I mean, and not addressing the prevention. So So, I mean, we all do it in clinical practice, and I wanted to sort of strengthen that also in prevention. Yeah, I think that's why. And then because my way in was epidemiology, and that's very much, you know, prevention.
Well, so can you talk to us? I mean, obviously, we've talked about your kind of glowing biography, but was there any particular scientific achievement or a particular moment in your career that you're particularly proud of, or something that you'll tell, you know, your children and your grandchildren about?
No, it's yet to come, I think. No, well, there are a few things. There's not one particular. I'm glad I put focus on smoking and the gender difference. I think that resonated at the time. I'm glad I put focus on socioeconomic and psychosocial factors. Particularly, I think, you know, and I think we're moving there now also, that it's not just the traditional risk factors, smoking and lipids and so on, hypertension, because we've got that very well under control, I think. And now we're moving to the more difficult risk factors or risk markers. And some important risk markers are socioeconomic factors, but also psychological and psychosocial factors. And their gender comes in also. Depression, we know, is twice as common in women, and this is a driver of cardiovascular disease also. I've looked at vital exhaustion, which is also maybe relevant also for physicians with burnout and so on. It's a sort of, when you move further from burnout, you become exhausted. That's also something we don't know whether it's causal, but it's certainly something that's a marker of risk and of cardiovascular risk. So, you know, these things seem to be these things also seem to be accumulate in women also. So it's not really that I'm looking very much at women. It's sort of just the things. I think it's more the other way around when I look at things, and then it turns out, okay, it's more women that seem to have these issues. But I've moved away a lot from prevention also. I like to do clinical studies and trials, because when you do epidemiology for a long time, you're sort of describing things. And at one point, at least for me, and I think for a lot of other people also, you get sort of a bit weary of describing. You want to do something about it. And then you move into some more trials. I know you've already done your important trials, Rasha, but I've moved more into sort of trials and clinical studies to have more impact on changing what we're doing rather than describing the problem.
And so you've talked to us a bit about how your career has changed and kind of the focus has changed. I mean, we all know academic careers and all careers have ups and downs. Are there any particular, difficult moments that you might remember, or something constructive you can share with our audience today about a particular moment that in your career that you won't forget?
Well, I considered that question, and I don't think there's sort of particular difficult moments. There were difficult periods, and those periods were when I was raising 3 children and trying to do a career at the same time. It was difficult to publish a lot. My publications certainly went down during that period. But if there's a message in that, don't worry about that. You can catch up later on. And the other difficult period from a scientific point of view is probably now, because ESC and the clinical practice guidelines are really taking so much of my time that it's very difficult to I have PhD students, and and it's difficult to keep up with the science while I'm doing all of the ESC work and the CPG work. So right now it's a sort of scientifically a bit difficult to balance things, but not any specific points in my life. No, that I can.
And is there, do you have any tips as to how you carry on being productive and how you carry on having the energy to keep doing this throughout your career?
Well, choose your spouse well. That's important. Share the work that and the private life. Share it well. Choose your family well, and then make sure you think it's fun. Work with people. Don't do it alone. Work with people that you think it's fun to work with, so that everything continues to be fun. And don't always measure yourself against against everybody else, what they're publishing, and don't get stressed about that. I mean, make sure you do what you think is interesting and that you do it well, and don't worry so much about the impact factor and what your peers are doing. That might take away some of the fun. If you're too focused on Twitter and everybody else's impact factor, it might take away some of the fun, and the fun should be driving the research.
I like that. Those are wise words. It's all about the fun, Filippo. We'll bring you into the conversation because we're chatting away.
Yeah, well, really fascinating conversation. I'd like to start with a question which stems from your initial study on women, smoking in women and the increased risk of MI. And you say this had been overlooked, probably because the risk of cardiovascular disease in women was not fully appreciated. That was some years ago. After this your initial experience, do you feel that in Denmark and perhaps in Europe, cardiovascular disease in women are taken a bit more seriously, or you think there's still a gap? From epidemiology, European epidemiology, we know that the risk for a woman to die of cardiovascular disease is 10 times higher than the risk of dying from breast cancer, which means that prevention of cardiovascular disease in women is 10 times more important than prevention of cancer. So what has been the evolution, in particular starting in Denmark, which is a very interesting country where women are really well taken into account? Do you think there have been improvement in this underestimation of cardiovascular disease in women in the last 10, 15 years?
Well, first, I think I'm going to say something that may be a little controversial, but it's a fact, and that is that men don't live as long as women, and that men also get myocardial infarction at a younger age than women. And I think sometimes all of these discussions about gender, they overlook this a bit, that it's still more of a male disease than it is a female disease. Now, having said that, I fully recognize, and that's what I've been interested in also, that there are a lot of issues with women that have been underappreciated. But I think a lot of that is that women don't fit into the usual. I mean, we've had this wonderful history that we've found out what is atherosclerotic disease. We've seen the stenosis. We've developed treatment, and we're sort of we know how to treat that, and we do that very, very well now. The mortality after a myocardial infarction has gone down so much, even the cardiovascular mortality. We know how to treat that, but then women don't always fit into that. Women have, 20% of women presenting with non-STEMI don't have any obstructions. So, and that's where women don't fit in well, and women get Takotsubo, women get scared, women get, Inoka, and so on. And that's where we are now, which I think is really interesting. I think it's because we're in so good control of the traditional cardiovascular disease that now we can focus on the women. I don't think we deliberately there's no question, we don't deliberately undertreat women. And I'm not sure that even some of the registries and the studies saying that women are being undertreated and underdiagnosed, and I'm not sure they are all right, because sometimes we use measures like women should have just as much angiography and they should have just as much PCI and just as much CABG. And if they don't have that, then we're undertreating them. But I don't think that's necessarily right. If women are suffering from something, there's more to the story than that. That maybe women that don't, the condition is different and should be treated differently. So, but get back to your question. I don't think in Denmark that we are under-diagnosing or under-treating in a significant way, no. But then that's my perception. Sometimes the statistics, you need the statistics and the data to tell you whether you're right or wrong. But you shouldn't always take the statistic at face value, I don't think. You need to go more into it. Does that sort of address your question, Filippo?
Your answer has been very, very clear. And this is an issue we will continue discussing in this dialogue, because it is really a relevant issue. But again, in the field of sex-related potential inequities, now let's face this issue not regarding patients, lady patients, but women in career. And there are three main areas in which these inequalities are relevant. One is authorship. There are less authors among women than among men. Enrollment in trial also is frequently not well balanced. And also career might be difficult for women. Can you share with us your views in these three settings: authorship, enrollment in trials, and career? Sex-related inequality in these three areas. What do you think?
Well, for authorship, I think it's a little bit of what we maybe Rasha and I were discussing before. Authorship, there's this issue with the leaking pipe. We see that in Denmark, and I think we see that in many other countries. We have a lot of women doctors. We have a lot of females enrolling to cardiology, and a lot of women writing PhDs. But then after the PhD, something happens, and that's sort of the leaking pipe, and that's where we only have 2 female professors in Denmark. And you know, this is the multifactorial, of course, this leaking pipe, but that must be what's reflected in the authorships. That women sort of they do their initial research, and then they sort of move away, and there are many reasons for this. And some of the reasons are women tend to be modest. I think we know. I don't know. I'm not modest. Not saying that men are not modest, but women tend to not have the self confidence, not have the same. I mean, we hear that from everywhere where women are asked to give presentations. I know that's what I heard from the clinical from the Congress Program Committee. Women more often say no when they're invited. We hear that in the Danish Cardiology Society. Also, when women are invited, they're more prone to say no. They don't have the confidence. They want to be absolute experts in anything they talk about, and of course but men are just more confident. They say yes. I mean, we know that in a lot of situations, and women just need to stand up and just, even if we don't regard ourselves as the absolute top expert in the field, just say yes. You know, I've done that. I say yes, even when I don't feel. I say yes to becoming the clinical practice guidelines chair, even if I think that maybe somebody else could do that better. But you know, I can do it, and I do it. And I think more women have to say yes when they're asked, and more women need to become the role models, and you know, take that on. And then it'll be more fun, because there will be more women, and we will feel more comfortable when there's much more women on the stage being speakers and doing the research.
And what about trials? Can we improve participation of women in trials? Do you think there are barriers there which limit the participation, or it's just our sloppiness or laziness to
Well, it's sloppiness and laziness maybe, but it's also women are older when they get the disease. They have more comorbidity. So then when we put down the inclusion criteria for trials, we need to consider that, you know, maybe be a bit more pragmatic in who we include. Women have more elderly husbands they have to take care of. That's a fact also, and with morbidity and you know, so we have to address these things when we design trials. Also make it easier. More pragmatic trials, maybe hopefully they could include more women, and then have it as a, you know, you continue as a criteria for, and that's true already. That's required from trials, that you have to have, you know, a certain amount of women to be able to draw conclusions on that gender also.
Thank you, Eva. I'm reading a question from Dr. Sanchez, Enrique Sanchez, but he's also with us. Perhaps, Amelia, can we mute Dr. Sanchez? Can you ask your question directly?
Okay, you hear me?
Yes, very well. Speak
Okay.
up.
Okay, thank you. Thank you very much. Professor Prescott, I'm interested in your view about hormone replacement therapy or menopause replacement therapy. Besides the classical cardiovascular risk factors in females, I would like to very much to hear your view as a woman that has been doing research in female cardiovascular prevention. Will you please tell us a little more about that?
Yeah, well, it's a complicated issue. I'm sure you know of the trials, but I agree with the current recommendation, which is that hormone replacement therapy in women after the menopause or during menopause should be restricted to a limited period where it's necessary for various reasons, for symptoms, and not be used for cardiovascular prevention. Of course, you need to balance that, but if there are a lot of symptoms and so on, if you have a history of osteoporosis and fractures and so on, you need to balance that. But it shouldn't be used as definitely not as to prevent cardiovascular disease, and we should try to avoid it if you have a high risk or even have developed cardiovascular disease.
Thank you, Eva. There is also another provocative question from Elisa Agustini in Italy. The question is, we said before, the probability of women to die of cardiovascular disease is much more than cancer. Is this is the question from Eloisa, is this because we treat breast cancer better than cardiovascular diseases? I know there is no easy question, no easy answer to these questions, but what is your gut feeling?
Well, you compare only to breast cancer. Women can get other types of cancer also, lung cancer, gastric, what do you call it, colon cancer, and so on. If you put all of that together, there, the risk in women is quite high. But yes, it's underappreciated sometimes that women's risk of cardiovascular disease is as high as it is for breast cancer and higher. So I don't think you can compare the treatments as such, can you? A lot is happening in cancer treatment also, improvement. A lot of the risk factors are common to the cancers and the cardiovascular disease. We have our treatment and our prevention has been so good in the recent years, bringing down the incidence of cardiovascular disease and improving survival. And I think that's what's happening now in cancer. They're improving their treatment very much. So I think we're going to be probably like this in the future, both improving. I don't know. I hope we can keep on improving cardiovascular disease. We've done so much in the last 2 decades. I don't know whether we can keep that up. Not many new drugs are coming out, but we'll see.
Yeah, I think that perhaps there are also differences, because in cancer, what really matters is an early diagnosis. Yes. If cancer is stage 1, then the vast majority of these patients really are well treated. While with cardiovascular disease, prevention, the mantra of prevention is more important. I mean, we want to prevent. When we see clinical disease, it's already too late. But I see that Eloisa is with us now. Can you unmute Eloisa? Eloisa, are you happy about the question? I'm sure you're happy about the question, the answer given by Eva, but do you have additional comments?
Yes, because I would take advantage of this special and extraordinary intervention of Professor Prescott, because I really think that we are still working in the setting of female diseases, cardiovascular diseases, using classifications identical to those of male patients, using grouping patients, age and risk factor, more or less with an adaptation as we did in the past. We didn't move through a real gynecological interaction in working with women cardiovascular diseases. I have now a 15-year experience in breast cancer and in cardiovascular diseases in women. And honestly speaking, I think we need to go more searching for support, collaboration, and research, and detailed information on the gynecological history of these women. A stupid fibroid can be a problem, can introduce estroprogestinic treatment in the life of these women, and we don't know because we don't even ask. Spontaneous coronary dissection is a black hole. We are totally unprepared to manage these women. And I think this is a major problem, probably largely underestimated in our population. The reason of my intervention is because I know that Professor Prescott can eventually consider these issues, in particular, a special collaboration with gynecology in the future documents, especially in investigation that cardiologists should do in this setting.
Thank you, Eloisa. Eva.
But that was, I think you're completely right. We have, and I think that's what some of what I was touching on earlier. Also, we've been so focused on this male phenotype, which some females fit well into that, but a lot of women don't. And now we've sort of we have some space now to look into that, because we manage that the male phenotype very well. So now we're focusing more on this female different phenotype. And I think also the pregnancy, I think more and more we're realizing and taking into guidelines also that we need to look at the obstetric and gynecological history of the women, particularly the pregnancy seen as a stress, a cardiovascular stress situation, you know, with all the preeclampsia and diabetes and so on, taking this into account. And I think it's very interesting. There's a lot of things there that I don't know. I think it's very interesting to think more about, you know, collaboration between gynecologists and cardiologists on this. Yes, good point. Thank you.
So Eva, could I come in with the next question from my side, if that's okay? Because we're talking about kind of this wider conversation about risk factors and maybe some of the non-classical risk factors. How do you feel about, you know, the impact of the environment, socioeconomic state, the various risk factors that maybe we haven't discussed yet, and where do you think the study and the research will go in that point of view?
Yeah, well, these are, you know, things that we as clinicians are a bit out of our hands, right? If we talk about pollution and climate changes that lead also to more cardiovascular disease, probably with the temperature rising, and socioeconomic difference and so on. But there's so much, you know, drivers of disease, we can't ignore them. And we are very much, you know, people we are listened to, and we can drive research. So when we do research into pollution, we may not be able to impact the individual's exposure to pollution, but you know, it's very, very important that those who are driving changes, that they realize that, you know, this is not just a question of, you know, it's something that's going to impact people's health. And the same is very much true for socioeconomic differences. You know, there are a lot of things driving, and socioeconomic differences are increasing within countries in these years. I suppose particularly maybe in your wealthy country, you've got huge socioeconomic differences, I think, and you know, we need to put that piece of the puzzle in there also, that the socioeconomic differences are not, you know, they're driving these diseases we take care of. So we have to address this, and not just address it on that level. And as cardiologists and clinicians, we also need to address it. I think we can't treat all the patients in the same way, because then in that way we'll just be promoting disparities in cardiovascular disease. We need to focus more on those in more need, and that includes those that are more deprived. So we need to be, you know, be a voice for these patients, for those who are politicians and so on, that this is driving the inequality in health, but we also need to address it in our clinical practice. I think more and more that one size does not fit all in everything we're doing, including this.
Thank you, Eva. And then it brings me, I guess, to the next question, which is obviously you've done a lot in the world of prevention, but now I'd like to talk a little bit about what you're doing in terms of the study of microvascular disease. And we know that you're running a big trial at the moment and recruiting to study this. What can you tell us a bit about what you're learning?
Yeah, well, it's not a trial, it's a study, but we did multiple small trials, sort of pilot trials within it. But it's a study where we tried to, at the time, this was started several years ago. At the time, there was everything on microvascular disease was sort of in very small studies, looking at microvascular disease from with various methods and sort of no large systematic studies looking at how common is this, it takes. So we took every woman who was referred to invasive angiography in a large area of Denmark, and if they didn't have any significant stenosis, we invited them into this, and we did echo coronary flow research. That's been criticized a lot, but we had to do something non-invasively, and we didn't have access to PET, and echo is really underestimated as a good reproducible measure of coronary microvascular function. So this is what we did, and we aimed at 2,000 women, and we actually got 2,000 women in. Some of them were healthy controls, and now we have that large population. We did look at their echo, their symptoms, and we also published their prognosis. And the most important findings, I think, is that it's very, very common to have microvascular dysfunction among these women. It was only women. More than 30% had microvascular dysfunction, and that and when we follow them, we see that those with microvascular dysfunction have approximately twice the risk of developing adverse outcomes. And that was we published that in the European Heart Journal, your journal, Filippo. They published that a few years ago. So that's that shows that it's not these small meta-analysis have confirmed this, but this was the first systematic study of women that took everyone in. We've seen it now also in PET registries and so on. Microvascular dysfunction is associated with adverse prognosis, and now we're sort of following up on that with trying to look more into mechanics and running trials looking at because we looked at biomarkers. We recently published, we looked at biomarkers in all of these women, more than 1,600 women. We assessed biomarkers also, and we found that coronary microvascular dysfunction is linked to inflammation, perhaps not surprisingly, but for the first time we did it in a big cohort, and we did it with multiple biomarkers, and it's just strongly linked to inflammation. It's also strongly linked to indicators of hypertension like renin and adrenomedulin, such biomarkers, and then it's linked to pro-BNP, so it's probably also linked to early remodeling, perhaps diastolic dysfunction and so on. So I think I could talk about this for a long time, but we've had some important findings from this, and we're learning more now that we have more follow-up. We're going to look more specifically at development of heart failure, and this is also guiding us into trials with addressing inflammation in microvascular dysfunction. So yeah.
So it sounds like, you've obviously taken on a number of topics at a point where they needed to be highlighted, or people needed to be aware of conditions that perhaps we were ignoring. But can I now ask you maybe a little bit about cardiac rehabilitation? Again, this has been a focus of some of your work. And I think, I can certainly speak for the UK, we're pretty terrible at recommending cardiac rehabilitation, and our services aren't really set up to maybe deliver it at the speed or at the detailed levels to really have impact. What do you think the recommendations are going to be on this, especially worldwide, and especially in a scenario where we don't have a magic money tree so that we can pay for everything? What would you recommend?
Well, first of all, I recommend, if you're talking about money, do some cost effectiveness analysis, and you'll see that rehabilitation is something that's not really that is cost effective. But there's really a funny discrepancy there, because whenever you go to patients, and the Danish Heart Foundation, of course, is driven very much by patients, and patients are always asking for more research in cardiac rehabilitation, because they feel, who's going to pick them up afterwards, who's going to, they just feel that that's where everything comes together. They go rapidly through intervention. Nowadays you stay 1 or 2 days in hospital, even with a myocardial infarction. You're sent home, and you take 3 or 4 new medications, maybe even more, and you have to change your lifestyle, and you're completely confused. And then you've got this cardiac rehabilitation that picks you up and sort of makes you understand why it's important to take this medication, why it's important to get on with your life, starting being physically active, pick you up with the depression and the anxiety that sometimes develops afterwards. This is hugely important for patients, and it's so has been perceived as really unimportant for doctors and cardiologists, and that's sort of a discrepancy we need to, still need to address. I don't know how I think it's not high status area, and I'm a non-invasive cardiologist, right? And already when you say non-invasive, you're saying I'm lower status than an invasive. And all cardiologists, you say we all split into invasive and non-invasive, and then that's sort of a hierarchy. We don't maybe not say it out in the open, but it is sort of a hierarchy. And then if you split that even more, the ones in the lowest in the hierarchy is going to be those who deal with cardiac rehabilitation, and that's just absurd. We need to address that as a community, in that we stop maybe we stop using this interventionalist and non-interventionalist, and start recognizing that everything has importance here from the patient perspective. We're always talking about patient's perspective. If we take the patient perspective, rehabilitation is going to be really important. So
I think that's a really good point that you make. They almost have a kind of negative connotation. There's the interventionist and the one who's not going to intervene. And that's Filippo, maybe that's a subject of another dialogue one day, how we change the way we talk about each other, and the kind of the hierarchy that exists within cardiology. You're right. I think that's a fantastic point.
Yeah.
I think that, thank you, Eva, because your comments are really important. I personally believe that to improve the risk factor profile is even more invasive than cardiac surgery, PCI, because you must reach the brain of the patient to be effective. This means that you have to create empathy with the patient. This means that you must be, as a doctor, motivated. This means that we have to give a good example. If the doctor smokes or is obese, it's difficult to convince patients about prevention. So the rehabilitation is the really ideal setting where, as you say, we can spend more time with our patients, motivating a good lifestyle. Takes time and effort. It's quicker to go for a PCI, half an hour, you relieve the stenosis. We know that in stable patients, usually this doesn't work. It's not effective, it doesn't improve prognosis and perhaps not even symptoms, but it is easy to stick a stent, half an hour, while to explain how important it is to stop smoking, it takes definitely more time. Yeah. So thank you for your comments, because this might explain also because all studies show that rehabilitation is associated with better outcome, probably because, as you say, it's the setting where risk factor control can be really optimized. But the dialogues are very interactive, and I can read two interesting questions. The first from Denis Clement. Denis, I see you. Amelia, can you please unmute Denis? Can you ask your question personally?
Okay, well, I am maybe also on the side of the non-interventional cardiologist, and that is in the peripheral area. When I look to the patients coming to the clinic of peripheral vascular disease, and also a little bit of the studies looking at this, I see that the regular patient with, I shall call it, intermittent claudication in most cases, it's more men than women. However, when you go to severe forms, I mean those complicated with ulcers and all of that, then you see it as well, at least as well, in women than in men. Now, is that, I know many colleagues have a little bit the same impression. Now, is that an impression? It's not really proven by statistics. It does not come out like that. What do you feel about this?
Well, I think I'm going to have to pass on that, because I don't think I have a very good answer to that, and I don't know enough. I have to be honest and say I don't know enough about it to be able to, you know, I don't see these patients very much, so I can't say what my impressions. I'm sorry.
May I just continue, Filippo? I just should say that this is a pity. We cardiologists are not enough attentful to the peripheral vascular system. It is an artery with atherosclerosis, exactly like the coronary arteries. And for a reason which is a mystery, we are not interested in that area.
Well, I can say from a guidelines point of view, we are very interested, and we're actually developing guidelines, and they will be published in 2024. Yeah. So, and I completely agree with you. And we can also assess risk much earlier if we measure the peripheral index. Yeah.
And also, the European Heart Journal, we have a team of editors dedicated to vascular medicine and biology. So really, we are aware of the importance, the relevance of this topic. And I see another question from Roberto Carbone. Back to Italy. Roberto, can you ask quickly your question?
Posso aprire? Aperto? Sì. I would like to know by Professor Prescott if there is the prevention, in particular in women, does exist a correlation in the studies, epidemiological studies related to pulmonary hypertension and at the same time the interstitial lung disease, for example. This is important, I suppose, when it is necessary to perform the cardiac surgery or the lung cardiac transplantation. I don't know if this study accurately in Europe or in Italy, especially the prevention in a woman, in particular pulmonary hypertension, in a correlation with correlated with interstitial lung disease, or especially or COPD, where it is necessary to avoid. And I listen to your previous discourse related to stop the smoker. This is another important suggestion. Is it correct to perform a cardiac transplantation, cardiac surgery, especially in the women when in the last period smoke? Is correct or no?
Thank you, Roberto. Any comments or answer, Eva?
I'm not sure I understood the question, to be honest. If it's correct to perform the
cardiac surgery in a woman where is not there is not the woman the interest to stop the smoker, for example.
Okay, who doesn't want to stop smoking?
Yeah.
And the cardiac surgery, you're talking about transplantation?
Another important question is the pulmonary hypertension is have an accurate point, and the point to make a clinical approach in a cardiac surgery. This is only my opinion.
Okay, I'm not sure I quite get it. You are suggesting that we should not perform cardiac surgery if a woman continues to smoke?
Yeah.
Well, that's in my country. That's you can't do that. You still perform whatever is necessary regardless of the lifestyle. So the same is true for obesity and whatever. you still need to treat the patient even if they can't stop smoking. You have to remember this is not something people choose. They are addicted.
Sure. Yeah, we must definitely work on prevention. Unfortunately, we fail frequently, but when prevention fails, we must move to our other forms of treatment. Now, I see in the audience Professor Sutton, Richard Sutton. Hi, Richard. Amelia, can we unmute Richard? Well, Sutton, any question syncope in women or other curiosity in women versus men? We have Eva here who can help us.
Syncope in women versus men?
In women versus men, yeah.
These are really difficult questions. I'm not sure what I mean, you have to help me out here. What the question is, are there differences in what causes or incidents or of syncope?
Richard, you are the top expert in syncope. What can you tell us about women and men?
Well, syncope is more common in women of younger age. So late teenage, early 20s, women exceed men by 1.5 or even twice. And this evens out through life. So eventually, men have more syncope than women in older age groups above 60.
But these are not cardiac syncopes, right?
Most of this is vasovagal syncope.
Yeah. Women have lower blood pressure when they're young, and then they have the pregnancies that reduce the blood pressure further.
And they have smaller hearts, which might also be relevant. And maybe more, if I use the right word, plastic peripheral vasculature. Because vasovagal syncope is beginning with vasodepression, and that's a loss, in inverted commas, of blood in the splending bed. So that may also be a factor.
Thank you, Richard. The more, the deeper we go, the more differences we find in the women. Now, Eva, you are a gifted clinician, an outstanding scientist, but let's change your hat. You're also the chairwoman of the guideline of the committee on guidelines, the European Society of Cardiology. And this is a big responsibility because really clinical practice, as we know, is guided by guidelines. So it's a difficult and important positions. What are the main challenges you are facing as a chairperson in this important committee?
The main challenges I'm facing
Sorry,
as a chairperson?
Yeah.
My main challenges?
Your main challenges in guiding this committee?
The committee, the challenge is to keep everybody, you know, we got these wonderful task forces of experts, 25 in each task force. We've got 8 ongoing task forces that, well, actually 12, because Paul will be presented here at this year's ESC. So the challenge is to keep all of those in line and keep them collaborating and delivering, and they do a wonderful job. But, you know, it's a big task. We have a wonderful team in the Heart House, and I'm sort of, to just keep all that in the process, you know, keeping the flow, keeping the quality, keeping the whole review. It's a huge machine, and that's just it's just a big challenge to be at the top of that, and not well at the top of that, but but it's also wonderful. It's a great job. I love ESC guidelines. I think they're the best cardiovascular guidelines in the world. I'm sure you agree, Filippo and Rasha, don't you?
Absolutely.
I think they're written by clinicians, for clinicians. They're very good, and they even become a lot better in the recent years with very good figures and flow charts, and we're trying to improve that even more with the methodology and so on, getting everyone on board with being more strict on the assessment of the evidence and so on. I think it's a great. I'm really enjoying it. It's a huge job, but it's a great job, and the committee, we have all the dedicated people. It's really, you know, people are putting, this is the people's spare time, and they're putting so many hours into this for several years. Everybody's doing that, and it's you know, and so it's, I don't know what I can say. It's overwhelming, and I think it's just great, and I love the result. I hope it's going to be just as good, the ones that come out when I'm chairing it, but I think they will.
Okay. So a lot of work, but really no specific challenge. Is really
well, there are a lot of small challenges, a lot of challenges along the way. You know, conflicts that need to be solved, disagreements, scientific disagreements, processes that and associations and working groups and so on that need to be respected. A lot of this sort of and guidelines, that task forces that have difficulties in getting to agreement. But you know, it's also very, very inspiring to do this. You know, it's great to be that and trying to help in that process. Yeah.
Eva, and let's come to your view of a guideline. In your opinion, to summarize, what are the 3 key points to fulfill for a guideline to be really outstanding? We know that our guidelines, and also and mainly thanks to the activity of the chairperson, we know that our guidelines are outstanding. But if we come to a specific guideline, what do you like more? What are the 3 key points which are important for a guideline to be really impactful and outstanding?
Well, you know, it's only once the guidelines are published and how they are implemented and taken, you know, acknowledged and accepted by the clinicians. That's only when we know we have done outstanding and good guidelines. You know, we can look at all kinds of things on internally. We can look at how they're presented and how well they're written, and whether the recommendations are the right ones and clinically applicable and all this. But in the end, I suppose we can only say that a guideline was outstanding if it is adapted to and you know, if it's accepted and used by the cardiologists. That has to be the hallmark, isn't it? I mean, we can say we've done a really good guideline here, but if it isn't implemented and used, then it's not an outstanding guideline. So, I mean, and
yeah.
what?
Yeah, I fully agree. And indeed, we perform surveys to check adherence to guidelines. Yeah. And we also published several papers in our journal showing that adherence to guidelines is associated with better outcome. So this is evidence that guidelines work very well. Rasha, any comment, any last remark on guidelines? Or
yeah, so I had one question for that. So obviously you have to motivate a guideline committee to help you work on this, right? And this is a big group of people, and you have some that do lots of work and some that do less. And I know myself, as I'm trying to pull together groups of people working together, how do you motivate everyone and keep them moving and keep to target? How do you get the people who are just being carried along to do a little bit more work? You know, how does that work?
That's a good question. You know, really, I think people are very much, well, they're driven by the, you know, it's prestigious to be in a guideline. But I think more than that, they're driven by the fact that EHJ guidelines are used so much. So you want to be there in the machine room when you're developing those guidelines, because you're sitting there with experts. I think that's very, very motivating. You know, you have a group of experts, of international, mainly European experts, and just to be part of that group is very, very motivating, I think. And then when you see when everybody's delivering, that's the whole process is very motivating. I think, you know, of developing, deciding what recommendations should be, looking at the evidence, having a vote, you know, having a discussion in the group with other experts, and then having a vote. You don't want to be there and not deliver. I think the whole process is so motivating that you don't want to be part of that without, you know, doing your best and delivering. And we don't actually see much problems of not delivering. You know, people are enthusiastic about being there.
And so I think we had a question from the audience, but we're probably right towards the end. Someone said, have you considered having trainees in some of these guideline committees?
Well, that's a good question. the quick response is not trainees. We need to have experts, but we do need to have a balance of senior people and younger people, because we need to, you know, enroll a new blood. So we do have this call every year. We do have an open call for that, what anybody can apply if they feel they have qualifications. And you should be aware that we have 4 guidelines every year. Once the topics have been chosen, then we put out an open call and anyone can apply. Last year, there were 900 applications. We go through all of them and we pick some of them to be part of the guidelines. So we do try to have, you know, younger, but it has to be sort of people who are know something about the topic.
Patients are definitely important in guidelines. They are present because our goal is to make our patients immortal, while our patients more simply tell us, please improve my quality of life. And frequently we forgot that this is one of our, or perhaps the main goal, to improve quality of life. What are your comments on this?
Well, that's spot on, Filippo. And I think the ESC is realizing that as well. And part of the ESC strategy is also to have more attention to patient-reported outcomes. And what people are saying, exactly what you're saying. And all of our trials have, you know, we look at the hard outcomes, which is very much mortality. And of course, that is important, but we need to get more. It's difficult, but we need to get more of these patient-reported outcomes, these quality of life, these other measures that are important to patients. We need to get them into trials and into the evidence base and into the recommendations without losing scientific rigor. And this is you know, something that we're addressing and needs to be addressed. Also in trials, need to report this more and include this more in the outcomes. And that, because that's what patients are asking for. That's what's important to patients, right?
Well, thank you. It is 1 hour.
Yeah, it went so quick.
It's been really so quick, remarkably quick, because it was so interesting. I have one last short question for you. What about our dialogues, Eva? How can we improve it? Any suggestions?
Well, you know, I think this is very. I think this is very good. You know, keep doing what you're doing. Ask interesting people, ask interesting questions, and specifically, you know, have an open dialogue with the people listening. I don't think I can come up with other suggestions.
So you encourage us to carry on with our dialogues?
Yes.
And this said by the chairperson of the guidance committee is particularly important. Well, Eva, thank you very much. Rasha, thank you very much for this quick dialogue, very interesting and passionate. And thank you, the audience, for your questions. This dialogue really a dialogue, so based on conversation and you all involved. I always encourage you to be active part of our dialogues. This concludes our dialogue. Next will be on, as usual, on the last Thursday of the month at 17 Central European Time, and in June, the last Thursday will be on the 29th. So please put your this date on your agenda, and we'll meet again in 1 month. Bye bye. Thank you again, Eva and Rasha.
Thank you, everyone.